Evan Lagers here showing my mature cataract removal in a patient a few weeks ago. This is a patient who had acute angle closure attack, likely from phacomorphic glaucoma. You can see the large PI temporal here. And after initial PI, his pressure came down to 9, then had repeat episodes, and even with the patent PI, his angle had continued to close. So we decided to take his cataract out in a semi-urgent nature after clinic one day. So first thing I'm doing here is making a paracentesis, and then I'm injecting epi-sugarcane to further stabilize the iris, especially due to the high pressure. These irises can be very, very floppy. Also helps to decompress the eye as well. We're going to use Vision Blue here. The air bubble will protect the central cornea, and you can see even just squirting the Vision Blue, there's a lot of back pressure, and it's hard to squirt the Vision Blue into the anterior chamber. We're going to let that sit for a minute. And then we're going to use our viscoelastic, which is Viscoat in this case, to hyperpressurize the eye. Because these capsules can be under significant tension, osmotic pressure internally, I find by hyperpressurizing the eye on the opposite side, we can decrease the pressure gradient across the capsule and decrease the risk of the capsule creating that Argentinian flag sign that none of us want to see. So right now this is actually BSS we're using to remove some of the Vision Blue. And then we're going to use Viscoat to tamponade down that capsule. You can see that we got our air bubble trapped over here. I think that GV is also a good option, Heal-On GV, for these cases because you do want to really highly pressurize the anterior chamber to equalize the increased pressure inside of the capsule. And as you can see, that bubble came out with the main incision, which I tend to make a little longer in these cases, and then I refilled again with viscoelastic to, again, firm up the eye as much as possible. Now here, when I make my initial nick, I just make a very small nick, and that's to allow any fluid to egress before proceeding on with the rhexis. These rhexi have a tendency to want to continue to extend, and so I think starting smaller and going out in a spiral fashion is a good option in these cases so that you don't lose your rhexis. We're going to take our time with this rhexis, really make sure that we make a nice, round, larger rhexis because of the density of the lens. Now, this patient was only in his early 50s, and I expected the lens to be relatively soft, but I was actually surprised to find how dense it was. And here I'm pulling backward and towards center as the rhexis was trying to sneak out on me, and that'll help redirect it in the appropriate fashion again. And as we turn the corner here, we're going to re-grab, again making sure to grab the flap and not any of the rhexis beyond where we've torn, because that can cause a tear out as well. And here I'm performing the little maneuver again to try to bring the rhexis in. And as you can see, we have a nice edge to the rhexis there. And we're going to bring this out and kind of spiral past where we originally started it to get a good sized rhexis to help aid in a difficult lens removal. I still like to do light hydrodissection in these cases, however, usually the lens is pretty freely mobile. And then we're just going to take this out in a divide and conquer technique once we're comfortable that the lens is free from the capsular bag. This would probably be also a good MyLoop case for surgeons that are facile with that instrument. And as we can see, this lens is a little denser than I expected. And I'll make a larger central groove in these cases to give myself better leverage. And a little bit wider, but not way, way out, as a nice deep central groove is really the key to a good crack. So I'm going to continue to take this out in a divide and conquer technique. Then we're going to do IA as we normally would. I do adjust my settings to decrease my aspiration flow rate and decrease my IOP and vacuum down in cases like this, as the bag tends to be very floppy. After that, we're going to put in a 3-piece in the bag, star CQ, which we have to enlarge our main wound for. This patient is now 20/40 uncorrected, with likely some optic nerve damage from his original attack, but with still very good central vision. Thank you all for watching. Please continue to watch if you so desire.